Good morning, everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and the Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you contraceptive methods. And this will be a part one, and another part will be later on. So, what we wanted to discuss about contraception, of course, we wanna, before deciding a contraceptive method, which should be safe and effective, to know the clinical and the social informations, which is important to decide. Second, to do physical assessment for the patient. Then, the medical eligibility criteria as proposed by the WHO and the CDC, and they categorize our patient into one of the four categories. Then selection of most effective method and discuss with the patient in details the advantage and disadvantage of each one. Then we will cover the hormonal contraception with different varieties, like injection contraception, like mini pills, like vaginal ring, like skin patch. Let's start. Clinical and social information include the medical history, menstrual cycle. All characters of the menstrual cycle is important, and its length, duration, and everything about it. And the pregnancy state of the patient currently, and the history, gravidity and puberty, breastfeeding, recent intercourse, presence of chronic disease like hypertension, diabetes mellitus, autoimmune disease, drug allergy, risk factors for thromboembolic diseases, future pregnancy intention, if she is planning later on, how many years she wanted to use contraceptive method, contraceptive experiences and preferences, very important to know about it, and sexual health, sexual practices, current and recent partners, and condom use, sexually transmitted infection, have any recent or past history of sexually transmitted diseases. Then go to physical assessment, and the clinician should determine the patient's pregnancy status before initiating contraceptive method. If you are in doubt that the patient may be pregnant or has a visit period, do pregnancy test immediately. Conduct blood pressure evaluation before prescribing hormonal contraception because it may aggravate the hypertension and may be risky to the patient. Monitoring the weight of the patient also may be useful, especially in certain hormonal contraception. And perform bimanual examination when needed, and the cervical inspection also. And this may occur with inserting an intrauterine device or fitting a cervical cap. The WHO and CDC recommend certain sheet to cover certain characteristics of the patient and any risk factors, and they categorize the patients into four categories. And according to the method of contraception, we have the intrauterine contraception, including copper-containing IUD and the levonorgestrel-releasing IUD, and the progestin-only contraception, including etonogestrel implants, dipomedroxyprogesterone acetate injection, and the progestin-only pills or mini pills. Also combined hormonal contraception, including the combined oral contraception with low dose senile estradiol less than 35 microgram, combined hormonal patch, and the combined vaginal ring. This is the sheet proposed by the CDC and WHO about medical eligibility criteria for contraception use. And you will see here they cover certain patient characteristics like age, like special habits, like smoking, like certain disease like diabetes mellitus, hypertension, heart disease, thyroid disease, thromboembolic risk. All these risk factors and the characteristic of the patient is covered in this sheet. And the different methods of contraception is mentioned here in the top. So from these sheets, this one and the next one, at the end you can decide this patient fall in which category, 1 or 2 or 3 or 4, according to certain contraception. I mean, one of the patient may be category 1 for barrier contraception, for example, but category 4 for COC, combined oral contraceptive. So it is dangerous to give this patient COC, while another patient may be category 1 or 2 for ID, and the category 4 for injectable contraception, for example. So it is not safe, the injectable contraception here. So according to using this sheet, you can categorize your patient, and this is the 4 category. Category 1, a condition for which there is no restriction for the use of the contraceptive method. Category 2, a condition for which the advantage of using a method generally outweighs the theoretical or proven risks. Category 3, a condition in which the theoretical or proven risk usually outweigh the advantage of using this method. Category 4, a condition that represents unacceptable health risk if the contraceptive method is used. And if we wanted to interpret and apply the categories in practice, we can say category 1, use method in any circumstances, whatever there is good resources or limited resources. While category 2, generally use the method, also allowed in both good resources and limited resources. But category C, use of method not usually recommended unless other more appropriate methods are not available or not acceptable. This is for good resources area, if you are working in a good resources area. But what if you are working in limited resources for clinical judgment? Then no, don't use the method if it falls in category 3. Category 4, which is the most dangerous one, method not to be used in both good resources or limited resources for clinical judgment. Select the most effective and appropriate method, and the clinician should discuss all available contraceptive methods that the patient can use safely, and this is the patient right to choose with the doctor after he explain all methods of contraception. And he should put the different types of contraception in order. He put the most effective and the most safe one at the top, and they say this is number 1 suitable for you, then number 2, then number 3, and so on. So you should put them in orders. Also, the ability to use the method correctly and consistently and the possible adverse effects should be explained to the patient. Information on non-contraceptive benefits of various methods, such as potential reduction of dysmenorrhea and abnormal uterine bleeding or acne, may help patients select and adhere to medication regimens. For patients with or at risk of sexually transmitted infection, dual method contraception, which combines condom and another method, should be discussed with the patient because you want to use condom as a barrier and protective from sexually transmitted infection. So we can classify contraceptive methods into three main groups according to its efficacy, and this is a recent one. Most effective means less than one pregnancy per 100 women per year. Like what? Like implant, like implanon here in the picture, intrauterine device, and sterilization, tubal ligation or tubal ring, or male sterilization by vasectomy. Less effective, 6 to 12 pregnancies per 100 women per year. Like what? Like injectable, like this one, Depo-Provera 150 milligram, given every 3 months, or oral pills, like this picture, or patch, skin patch, like this one, or vaginal ring, like this one, or using diaphragm, which is inserted in the vagina by the patient herself up to the cervix, like this one. So this is the second big group. What about the least effective one? The least effective one, 18 or more pregnancies per 100 women per year. Like what? Like male condom, this one, female condom, this one, withdrawal method by ejaculation outside the introitus, sponge use, like this one. This is the sponge. The patient inserted inside the vagina, high up, like natural family planning using measuring the temperature or, or using the safe period because there is rise of half degree at the time of ovulation. So she can prevent intercourse in these important days or safe period from day 11 to day 19. Or spermicide like this one, gel or suppository or foam. Okay, what about the hormonal contraception, which is very important method of contraception? We have combined contraception containing estrogen and progestin, or progesterone or progestin only. Example for combined estrogen and progesterone like COC, injectables like Misigina, vaginal ring and the skin patch. This is the vaginal ring and this is the skin patch. Or progestin only like mini pills as microlot, like injectable like Depo-Provera, and subdermal implant like Norplant here, 6 roots, injected subdermal. Okay, let us start with the very common hormonal contraception, which is combined oral contraception, and what are the types, and according to what we classify, according to the content, physics, dose, pills per pack, number of pills per pack. Content, combination of both estrogen and progestin. Phasic may be monophasic, biphasic, or triphasic, or quadriphasic. According to what? According to the dose in each phase of gestation mainly. May change over the cycle, and we'll see later on. Dose, according to the dose of acenyl estradiol, low dose from 30 to 35 microgram acenyl estradiol, or high dose like 50 microgram acenyl estradiol. Of course, the use of low dose is much better because it is less risky. Pills per pack. Usually bags contain 21 and all of them active, like this picture. Okay, so the patient will take 21 pills, then stop for 7 days for break, then again take another pack. While if the pack is 28, there is 21 pill active and the 7 inactive pills may be placebo or containing iron supplementation. So the patient has no break between the packs. She will take continuous because the 7 inactive pills containing placebo or iron is considered her break. So combined oral contraceptive may be monophasic pills like this combined oral pills, what's called the Yasmin, or biphasic pills like this one, or triphasic pills like this one. And you can notice there is different picture in biphasic, different color, sorry. Here 11 is white color and dark color 10 another pill. This triphasic 3 colors you will see in the back, indicating it is triphasic pills. This means that the dose is not the dose is not similar in all of them, and the difference usually in the gestation or progestin. Quadriphasic pills, as this picture, so we understand now the different physics of the combined oral pills. What are the examples of combined oral contraceptives? Here, microgynon. The active ingredients include levonorgestrel 150 mg and ethinyl estradiol 30 mg. Here is Marvelone containing desogestrel 150 mg and ethinyl estradiol 30 mg. Yasmin, ethinyl estradiol 30 mg and drospirenone 3 mg. Celeste, norgestimate 250 mg and ethinyl estradiol 35 mg. Each one has certain characteristic or certain benefit. What about the microgynon? The hormone in microgynon are well known and have been used for decades. What about the Marvelone? Can have a positive impact on acne. What about Yasmin? It doesn't cause weight gain. What about Celeste? Lighter, less painful periods. COC pill regimen. We start with the first day or at least in the first 5 days of the cycle, 1 tablet per day at fixed time, and continue according to the number of tablets as we said before, 21 all active and 7-day break, or 28, 21 active and 7 inactive pills, and then continue immediately. For breastfeeding women postpartum, please postpone till 6 months. But if non-breastfeeding women postpartum, delay 6 weeks after childbirth. If any missed pill, take any recent missed pill as soon as possible. And if 2 missed pill, you can take another pill and then continue. What is the mechanism of action of COC? Please look to this picture, mainly suppression of ovulation. By its effect on the pituitary, preventing release of LH, which is important for maturation of the follicle and the ovulation. This is the main effect of COC. Also, may do a change in the endometrium, making the endometrium unsuitable for implantation. Also, progesterone in combined oral pills cause thickening of the cervical mucus, which is become impermeable to sperm. Also inhibits sperm capacitation. Also, it has an effect on tubal motility, interfering with fertilization. What are the advantages and disadvantages of COC? Advantage: highly effective when used correctly. Use is controlled by women. Stop it when needed. Reversible and rapid return of fertility. Have beneficial health effect on treatment of certain diseases like adenomyosis, endometriosis. No effect on sexual activity, and this is important. What about the disadvantage? Incorrect use and the pill missing is common, and this may cause failure rate. Require daily pill intake and resupply. Offer no protection against sexually transmitted infection. Also, many side effects like increased risk for cardiovascular complication like hypertension, ischemic heart disease, thrombosis, and stroke. Also cause breast tenderness, skin pigmentation, breakthrough bleeding, and weight gain. Let us go to next topic, which is progestin-only pills. This is some examples: microlot, levonorgestrel 30 microgram, micronor, norestestrone 35 microgram, xylitol, linesterinol 500 microgram. What about the regimen? Start at the first day of the cycle or in the first 5 days, one pill each day at fixed time. No break between the packs. So take the pills or this many pills continuously at fixed time every day. What about postpartum? Start 6 weeks after childbirth, one pill each day at fixed time without break between the packs. And this is one of the most suitable methods for lactating women, by the way. If missed the pill, take any recent missed pill as soon as possible. This is the microlot, an example of mini pills. Some of the package as microlot 35 tablet, other tablet like in the previous slides, micronor is 28, xylitol is 28, microlot is 35. Okay, what is the mechanism of action of progestin-only pills? Please look to this picture. It suppresses ovulation. Okay, it suppresses ovulation. Also, causing thinning of the endometrium, preventing implantation of the ovum, causing thickening of the cervical mucus, becomes impermeable to sperm. The sperm cannot penetrate the cervical mucus. Also through its relaxation effect on the fallopian tube, preventing fertilization or transfer of fertilized ovum. Advantage and disadvantage of many pills. The advantage is that it is safe and effective during lactation, easy, cheap, and available, no severe side effects like COC. The disadvantage include menstrual irregularities, needing daily resupply and continuously, not protecting against sexually transmitted infection, weight gain, acne, headache, breast tenderness, risk of ectopic pregnancy, less effective than COC. What about the next topic, which is injectable contraceptives? We have two big groups: progestin-only injectable, which we give the patient at the first 5 days of the menstruation, an intramuscular injection of either medroxyprogesterone acetate 150 milligram or norethistron enanthate 200 milligram, but in Depo-Provera, the first one, we give it every 3 months, but in norethistron enanthate, we give it every 2 months. This is the difference between both of them. What about the combined injectable? Combined injectable contain both estrogen and the progestin. It is given also early in the cycle, in the first 5 days of the cycle. And I have two types, Misgyna and cyclofem. What is the difference? Misgyna contain 50 milligram medroxyprogesterone acetate plus 5 milligram estradiol valerate. And the injection is given every month. Cyclofem contain 25 milligram medroxyprogesterone acetate and 5 milligram estradiol cypionate. Also, injection is given every month, and this is a picture of each one of them. Again, what is the advantage and disadvantage? As regard the progestin-only injectable like Depo-Provera, it is safe and highly effective, long-acting but reversible, require no action at the time of intercourse, offer non-contraceptive health benefits in certain disease, can be used by breastfeeding women. While the disadvantage, menstrual changes, return to fertility is usually delayed, no sexually transmitted infection protection. What about the combined injectable? What is the advantage? Being safe and highly effective, less menstrual disturbance, require no action at the time of intercourse, return to fertility is more rapid. What are the disadvantages? Menstrual changes, estrogen-related side effects, cannot be used by breastfeeding women, no sexually transmitted infection protection. What about the subdermal contraceptive implants? We have Implanon, Norplant, for example, and the others like Uniplant, Nestron, Norplant 2, and Sino implant. Okay, Implanon, only one root or one capsule, while Norplant is 6 roots. Injected subdermal, as you see in this picture. This is one root, this is 6 roots, this is 2 roots, belong to Sino implant. Okay. In Implanon, it releases 40 microgram per day ethinogestrel. Ethinogestrel per day. Removed after 3 years. While Norplant release 85 microgram per day, then after 9 months decline to 50 microgram, and after 18 months decline to 35 microgram per day. And this continue for 5 years, so you should remove it after 5 years. Implanon, single root, removed after 3 years. Norplant, 6 roots, removed after 5 years. The other types may be 1 or 2 roots as mentioned before. Okay, this is how to insert it. There is certain equipments to insert the roots in the upper arm, the inner side, subdermal. Here, single root for Implanon, 6 roots for Norplant, and here 2 roots for Sino implant. What are the advantages of these implants? Safe, effective, long-acting, and reversible. What is the disadvantage? It is considered a minor surgical procedure. Amenorrhea, or irregular bleeding, weight gain, acne, headaches, and breast tenderness, nausea, vomiting, headaches. What about the next topic, which is birth control patch? This transdermal contraceptive patch is safe and convenient birth control method, but not available in all countries. It is available in USA. It contains estrogen and progestin, so it is combined hormonal method. The patient should put the patch on clean, dry skin in the upper outer arm, for example, or buttocks or back, as you see in the picture here. This is the patch. This patch changed every week, up to 3 weeks. So the patient takes this patch 3 times per cycle, every week, one patch. At the same day, she remove one and put the other immediately. And try to put the patch away from friction sites or sites that interfere with wearing clothes. So this is important point. And try to be sure that the patch is present every day and not fall down. What about the vaginal ring? The vaginal ring is one of the combined contraceptive methods because it contains estrogen and progestin. It is flexible, soft, elastic ring, like this one. This is the vaginal ring. And this is how the patient hold it to insert it high up in the vagina, up to the cervix, to keep it in place. It continues for 21 days. Then remove it and it takes 7-day rest. Then again repeat and insert a new vaginal ring. It's similar in action as other combined contraceptive methods like COC, for example, because it contains estrogen and the progestin. If the ring fall down during the cycle, please wash it with clean water and reinsert it again until you finish the 21 days. And you start at the 5th day of the menstrual cycle to insert the ring. Other transdermal methods like Progestin-only patch, transdermal gel and spray, mistrone, and metered dose transdermal system, which is fast-drying liquid formulation used in a non-occlusive spray and can deliver mistrone through the skin surface via precisely engineered system. And this is the Nestra gel, which is suppress ovulation for 21 days, well tolerated, no androgenic properties, applied in dose 2.3 milligram per day, once for 21 days with 7 free days. And this is the last slide containing many types of contraception. I want just to name it. This is combined hormonal method skin patch. This is tubal ligation, and this is ID and COC and vaginal ring, and this is spermicidal gel, and this is cervical cap, and this is measuring the temperature and safe period as a method of contraception. This is Norplant with Secrets subdermal injection. This is the vaginal diaphragm, how it locks, inserted high up in the vagina of the cervix. This is the microcep, one of the combined COC. This is the vaginal sponge inserted in the vagina. This is the cyclofem combined estrogen and the progestin monthly injection. This is male condom. This is female condom with 2 rings upper and lower, and one closed end. This is the vaginal condom. This is the vaginal ring containing estrogen and progestin. And this is Depo-Provera progestin-only injectable given every 3 months. And this is progestin-only pills containing only gestation or progestin given continuously without any break. And this is the end of my lecture. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine.